Zia Vision has been wonderful supporting this research that I'm doing in my own practice in Tacoma, Washington, where the majority of the people I see have diabetes. So I'm across the street from a large endocrinology practice with 6 docs, and so I see a fair number of people with diabetes on a daily basis. About 9 out of 10 people I see have diabetes, and as Chris alluded to already, I've had type 1 diabetes myself for 45 years now, just turned 50. And got proliferative retinopathy in the mid-1980s and knew nothing about the eye at that point in time. So I've kind of, lived the life of the non-compliant person with diabetes like many of my patients have. Every mistake that could be made, I've made, believe me. So the study that I've been working on with Zia Vision is the Diabetes Visual Function Supplement Study. And it's registered with clinicaltrials.gov, and I'll talk more about that as we move through. So the first question I think it's worth asking is why is this something that we should even consider? Why should we think about nutritional support or micronutrient support for diabetes? Because after all, right, photocoagulation works, and we know very well that it saves vision on a daily basis, that you're much less likely to go blind or suffer severe visual impairment from diabetes than you were in decades past. The estimate is that about 90% of severe vision loss from diabetic retinopathy is avoidable by instituting good diabetes control and having regular dilated eye exams and timely treatment, right? And that's what we're all about and part of with our patients. But the reasons we should care, I think, is first of all, laser does not always work, right? And there are side effects from laser treatment. The number one cause of visual field defects in people with diabetes is post-laser scotomas. I see a fair number of people that have excellent control of their diabetes, and they still develop severe sight-threatening diabetic retinopathy. Most people, though, in fact, have suboptimal blood glucose, blood pressure, and blood lipid control. And I'll show you some statistics about that in a moment. The other thing is that, diabetes, of course, is a growth industry. It's really an epidemic, about 2 million additional cases being diagnosed every year in just the United States alone. And we have another 80 million people with pre-diabetes in the US. And these are people that the majority of which are going to develop diabetes within the next decade is what the projection is. So it's probably literally going to bankrupt our healthcare system. The other thing, it's not up here, but optometrists, I think we are a proactive profession. We don't wait for things to go to hell before we try to intervene and help patients avoid visual catastrophe. So I think it's incumbent on us as primary care eye docs to talk to our patients about prevention. So that's another reason I think we ought to care. So it's the notion of being proactive rather than simply reactive, because as we all know, it's better to stay well rather than to cure yourself once you get sick, right? It's easier to stay well than to get well. My wife's my practice partner. She's an optometrist, and she has this in a big placard behind our examination chair in our main examination room. And my patients are always pointing to that and asking about that. That's a great saying, and it really is. So the question that I'm going to try to pose tonight is, can we bite the various hands that feed the development and the progression of diabetic retinopathy using nutritional supplements? And I did a pretty extensive kind of literature search to see how many studies have been done really looking at this question. And I only found one. It was a German study done using an antioxidant multivitamin that had basically an AREDS type formula. And they showed that if you gave patients this for 5 years with mild diabetic retinopathy, they did not get bad, their retinopathy did not progress at the same rate as patients that were given no supplement. So there seemed to be a mitigation of the progression of the diabetic retinopathy. But that's it. I really couldn't find anything else done in humans. Really, I think we can use macular degeneration as a working model, and in fact, macular degeneration in diabetes and diabetic retinopathy share a lot of common features. They're both the major causes of vision loss in older and younger patients, respectively. And we already know with AMD that we can reduce the risk of progression. That was demonstrated by both AREDS and AREDS2. Maybe not to our satisfaction, and maybe not enough of a reduction. Most people still progress, but we could reduce the risk of progression. And so that begs the question, can we have a similar effect with diabetes and diabetic retinopathy? We also know that macular pigment optical density and the carotenoids that build it up, the xanthophylls, zeaxanthin and lutein, improve visual function in macular degeneration. So that begs the question, will it have the same effect in diabetes? And there are a few studies that look at that, including the one that I'm working on now. So this is a retinal biologist at, I believe it's Kresge Eye Institute, Renu Kalaru, a PhD retinal biologist, who wrote a very provocative paper, I thought, a few years ago, published in IOVS. And she asked this rhetorical question, you know, is it in fact time for us to develop some sort of a multi-component product, a la the AREDS 2 or the AREDS formulas, that maybe will have a positive impact on the progression and the development of diabetic retinopathy? So what are some of the common threads between AMD and diabetic retinopathy? Well, they're both major causes of vision loss. I already said that. They both cause oxidative stress in the eye. So AMD, primarily, there's oxidative stress in the retinal pigment epithelium. In diabetic retinopathy, it's more in the actual photoreceptors than it is in the RPE. The other thing is that both diseases cause the release of inflammatory proteins, these cytokines, things like tumor necrosis factor alpha and other inflammatory proteins that lead to blood vessel damage. Both diseases involve an increase in vascular endothelial growth factor, right? And that's why anti-VEGF drugs, Avastin, Lucentis, and the like, are used for both diabetic retinopathy and age-related macular degeneration when it's exited, as we all know. And both diseases do impair visual function, including things like your contrast sensitivity, your color vision, and visual fields. So there was a study published last year that showed people with diabetes had subnormal visual fields even when they did not have diabetic retinopathy. So there seems to be a diminution in the visual field sensitivity in people with diabetes. And the same thing, of course, with respect to AMD. So I glossed over this, but both diseases involve something called AGEs, which are advanced glycation end products. And that's what is on your turkey that you eat at Thanksgiving. When the glucose that's in the skin of the turkey binds non-enzymatically with the protein in the meat, you get this caramelized, beautiful golden brown, delicious texture to your turkey, but that's full of these products called advanced glycation end products. And these form in the body all the time whenever glucose levels rise even a little bit. So all of us have these in our bodies. Well, essentially what happens in diabetes, because glucose levels are higher, we form AGEs at a much higher rate and to a much greater extent than in people without diabetes. What do AGEs do? They derange collagen, they derange proteins. They cause the aging process to occur, essentially. So AGEs, in fact, lead to aging. And the AGEs have been strongly implicated in both AMD as well as diabetic retinopathy. So AGEs are caused by non-enzymatic glycation of proteins that forms these irreversible chemical bonds. They don't go away. They stay there for decades. In fact, there is an instrument now that's been brought to market that measures AGEs in the crystalline lens of the eye as a marker for long-term blood sugar stress, essentially. So essentially, it's like the hemoglobin A1C test that our patients get done that shows their average blood sugar level. But instead of a 3-month period of time, you're looking at a 30 to 40-year period of time. How much glucose has the body kind of been subjected to? So high blood sugar levels in diabetes lead to increased AGE formation. And in macular degeneration, in fact, there are more AGEs in the RPE of the retina, in the retinal pigment epithelium. And AGEs in the retinal pigment epithelium interfere with the ability of the body's ability to clear drusen away. It interferes with lipofuscin removal. And here's just a little slide that was forwarded to me by my friend and colleague Stuart Richer from a paper that he came across showing that AGEs in the RPE interfere with the clearance of lipofuscin, which is one of the primary constituents in drusen. So in fact, they've shown in AMD, and this is not talked about a lot, but that eating a low glycemic index diet, so less refined carbohydrate, lowers the risk of developing advanced AMD about equally as well as does taking AREDS micronutrients. Now, it hasn't been studied with respect to AREDS 2, which of course has the xanthophyll pigments added to it. So let's talk more about diabetes specifically. It's a growth industry. Almost 2 million Americans getting it every year. About 27 million Americans now have diabetes. 9 million are undiagnosed is the estimate. And that sounds really crummy, doesn't it? 9 million, so about a third of all people with diabetes, it's estimated, in the US have not been diagnosed. Now, if you look at that number worldwide, we're actually doing better than the majority of the industrialized countries. In most countries in the industrialized West, half of the people in the population with diabetes, it's estimated, have not been diagnosed yet. So we're doing a better job actually of diagnosing it than many countries are. And we have almost 2 million new cases a year, as I've already said. By the year 2030, about 500 million people on planet Earth will have diabetes, is the estimate from the International Diabetes Federation that tracks such things. And I betrayed my age. I put up my favorite album from when I was a little kid. Does anyone recognize that album cover? Supertramp, yeah. Crisis, What Crisis. I loved that album. So it really is going to be a crisis. Now, metabolic control in the US is really not that good, and that's no surprise to those of us who are healthcare providers, right? So the estimates are that more than half of people with diabetes have an A1C above 7%. So what is a 7% A1C equivalent to in terms of average blood sugar level? If people have heard me speak in this room, a few of you have, I know, you probably know this already, but a 7% A1C is actually about twice normal. It's a 170 average blood sugar level. So that's pretty poor control, and that's kind of the minimal standard advocated by most diabetes organizations, is to have your A1C be at least 7%. But more than half of people with diabetes are above that. In addition, about 70% of people with diabetes have blood pressure levels that are above kind of the recommended targets, above 100. It's now 140/90 is the recommendation. So the majority aren't at blood pressure targets. So metabolic control, even though metabolic control does make a difference, we're not doing a very good job of doing it. But this begs the other question. How about if I have really good blood sugar control? What if I always keep my hemoglobin A1C at the ideal target of 6.5%? That's what the Academy of Clinical Endocrinology advocates. That's about a 150 average blood sugar. But even if you do that, and you have a blood pressure of 120/80, 1 in 25 people with that excellent metabolic control still will develop either clinically significant macular edema or proliferative retinopathy. Now, the majority won't, but within 10 years, a fairly substantial minority of patients with great control still end up with potentially blinding eye disease. Now, if you have a little bit of retinopathy and you throw that into the mix with the same great control, the risk goes up to almost 8.5% of developing sight-threatening diabetic retinopathy within the next 10 years. And this is based on data, actually, that came from a large cohort of people with diabetes in the United Kingdom and Denmark and Iceland, so about 30,000 individuals. So maybe not the most diverse, culturally diverse population of people, mostly white Northern Europeans, right? But the data comes from that a substantial number of patients, even with great control, end up developing severe eye disease. So here's a patient that I pulled out of my stack of patients from my office that I saw last year. He's 62. He's had an A1C at diagnosis actually that was under 6.2. He was diagnosed based on a fasting blood sugar test. So he has a good A1C. His blood pressure has never really been very high. So 6 years after diagnosis, he shows up with this kind of presentation. And I've seen this more often than you might think. Now, of course, it begs the question, how long did he have diabetes before it was diagnosed, right? Because we know by the time someone gets diagnosed with type 2 diabetes, on average, they've had the disease. The estimate is at least 5 years. So we are, in fact, even though we're doing better than most countries, we're diagnosing people late. And part of that problem, part of the reason for late diagnosis is we're not doing the right test. So the test done to diagnose diabetes is what? Fasting blood sugar. So I have type 1 diabetes. I make no insulin whatsoever. My blood sugar was 73 this morning. Does that mean I don't have diabetes? No. It means I didn't eat a lot of carbohydrates last night. This is basically what that means. So it's not a very good way to diagnose the disease to rely on that one test. So here's some real numbers with respect to diabetic retinopathy. The really key number here is that about 10% of people with diabetes, not just those with diabetic retinopathy, 10% of people with diabetes right now are estimated to have vision-threatening diabetic retinopathy. That's either proliferative disease or diabetic macular edema. And you can see the numbers worldwide. There's a lot of people with diabetes. So if you take these numbers, translate them to the US, it turns out about almost 28 million Americans with diabetes, and about 3.6 million have some degree of retinopathy. I'm sorry, 9.6 million, almost 10 million have some diabetic retinopathy, and nearly 3 million Americans have sight-threatening diabetic retinopathy. So we got a lot of people in trouble. So what's the best way to prevent diabetic retinopathy, do you think? Yeah, don't get diabetes, right? I mean, that's it. That's really the key. Don't get diabetes. But really,
have it treated.
If you have it treated, of course. But the key, if we want to save lives and money especially, is to prevent the disease. Because you're not going to go blind from diabetes if you don't get diabetes. So I think it's really imperative for all of us as healthcare providers to talk to our patients, especially those at risk, about how to prevent developing especially type 2 diabetes. And so I have a quick slide. I'm not going to talk, this is another 3-hour talk, but this is a list of my recommendations. So the bottom line is you want to walk every day. You want to eat a low glycemic index, Mediterranean type diet with more plant foods in it, less refined carbohydrate. You want to drink coffee because coffee, study after study, appears to lower the risk of diabetes, but so do green and black tea. Has nothing to do with the caffeine. The other thing you want to do is get adequate sleep. And this is not talked about a lot, but studies show you're 3 times more likely to develop impaired glucose tolerance if you sleep less than 6 hours a night. So you want to try to get adequate sleep. You want to live away from smog. People that live in smoggy areas are more likely to get diabetes, as it turns out. They've done studies in Germany showing the closer you live to a freeway, the higher the rate of diabetes is as you get closer in proximity to your residence to the freeway. Anything else on there? Breastfeed. Women who breastfeed are dramatically less likely to get type 2 diabetes. And it's about a 17% risk reduction for every year of breastfeeding. So if you breastfeed, I did the calculation, if you breastfeed to 13, you have 0 risk of getting diabetes.
What about fellas? I mean,
It's a little weird after 12, though, I think.
It's weird after 12, it's true. Right. When the kid enters, I have a middle schooler now, it's probably not something he wants his friends to see. There's another way to avoid diabetes, and I put this in just for fun, but in 1900, it's estimated that basically the entire world population had either tapeworms or roundworms. And now only about half of the world population has them. And so obesity, it's thought, maybe relates to these little critters in our intestinal tract consuming some of the calories that we ingest. And so they've actually shown in mice with metabolic syndrome and type 2 diabetes, you can totally reverse it by having them take on a roundworm, take on a parasite, take on a nematode. I just thought that was an interesting study. But what if I've already got diabetes? To this doctor's great question, you take care of yourself, right? So this is the recommendation, and these are great recommendations. Keep your blood sugar, your blood pressure, and your blood lipids as close to normal as you possibly can, safely, without killing yourself. So I had a patient last year, this is the 3rd patient I've had like this, type 2 diabetes, elderly gentleman, put on insulin therapy by his family practice doctor, patient died in bed, alone, of hypoglycemia. So you got to do it safely. You can kill people by lowering their blood glucose too much. The next thing is to get annual dilated eye examinations, right, and timely treatment. And these are the recommendations from the American Diabetes Association, the American Optometric Association, the Academy of Ophthalmology. We're all on the same page about this basic formula. But it does beg the question, is there anything else we can do to be more proactive than simply that? Is there any extra measure of safety or insurance that we can afford our patients? And so I'm trying to make the case that maybe there is, and that's what the research I'm doing is about. So it comes back to the question, what ultimately causes diabetic retinopathy other than just getting diabetes? It's a whole number of things, right? You've got elevated blood sugar levels. You've got high blood pressure. High blood pressure damages vessel walls. You've got inflammatory proteins being released that further damage blood vessel walls. There's oxidative stress. You've got growth factors being released that cause neovascularization and leaky blood vessels. There's hormonal influences involved. We know that you're way more likely to develop proliferative retinopathy when you become pregnant or when you go through puberty. That's the highest risk for people with type 1 diabetes, is in puberty, because growth hormone makes new blood vessels grow. It's like VEGF, does the same thing. Other things involved are apoptosis, right? Programmed cell death, we've all heard of that. And there's upregulation of all kinds of inflammatory cytokines that lead to blood-retinal barrier breakdown, right? So we all have a sense of what's going on. This is the little slide that I put together to kind of show all these pathways interacting with one another. The whole idea here is not to drive you nuts with the complexity of it, but is to show you that all these different pathways cross-talk to one another. You start out with diabetes, which essentially leads to hormonal influences, but really abnormal lipids, hyperglycemia, hypertension, growth factors, and all of that stuff leads to these intermediate pathways. Sorry for putting my arm in the way. And that leads to oxidative stress. And oxidative stress ultimately leads to apoptosis of the retinal ganglion cells. So long before a patient has a microaneurysm, retinal ganglion cells are dying. And that's why, on average, nerve fiber layer thickness by OCT is thinner in people with diabetes than those without, age-matched normal controls. So you get apoptosis of the retina and of the blood vessels, and you get inflammation, and that leads to blood-retinal barrier breakdown and neovascularization. So that's the model. So the question really I'm asking is, can we intervene in any of these pathways independently of simply lowering blood sugar, lowering blood pressure, which is really what the mainstay of treatment is now. So biting the hands of diabetic retinopathy involves intervening in all these pathways. So what did we study? What are we looking at in this study that we're doing now? So I'm going to give you some of the rationale behind each of the ingredients. So the first thing is, we know that both diabetes and diabetic retinopathy are associated with low macular pigment optical density. Richard Rosen at New York Eye and Ear did a study a few years ago showing that people with diabetes had lower MPOD than people without diabetes. And as your diabetic retinopathy gets worse, MPOD goes down. So again, it's a chicken and an egg argument, right? Does MPOD go down because you've got diabetic retinopathy, or is MPOD partially responsible? Or are both of those questions really kind of first grade questions? In my view, in a lot of ways, we always say, does this cause that, or did that cause this? Well, causality is a human concept, right? If something, a lot of these things are linked up in each other, and it's hard to tease out whether or not something is causal. And just as a quick aside, there are physicists now saying that the whole notion of causality is nonsense. It's absurd. It's the kind of question a third grader asks, which I just think is interesting. So physics is actually becoming more like metaphysics, more like philosophy as time goes by. But we know MPOD is lower in people with diabetes, and it's worse in people with worse retinopathy. As your MPOD level goes up, your A1C typically goes down. They're inversely related to one another. So if you have poor blood sugar control, your MPOD goes down. And in previous work in human patients, it's been shown that supplementing people with non-proliferative retinopathy, supplementing them with lutein and zeaxanthin in combination, actually not only improves their MPOD, but it improves their visual acuity, their contrast sensitivity, their foveal thickness based on OCT. So that's interesting. So there's an argument there for supplementing with these xanthophyll carotenoids. So here's just another study showing that in animal models, at least, that zeaxanthin and lutein both can reduce VEGF and inflammatory markers like nuclear factor kappa beta. And it ramps up brain-derived neurotrophic factor, this guy, which has been shown to be protective against diabetic retinopathy in animal models. So it might make sense to measure macular pigment. Now, this is the new quantify macular pigment optical density measuring device that ZeaVision makes. And I don't have the device yet. I've just kind of seen some slides for it. But the thing that I think is really cool for any of us who do MPOD in our practices, and I do it every day now, is that a lot of patients, a substantial minority, have trouble taking the test and being reliable. And you have to go back and repeat the test. And some people, at least in my hands, even when I do it 5 times, I never get good data. So they have a reliability index now that allows you to say whether or not you've actually captured good data. And I think that's enormously helpful. So the whole idea here is that raising MPOD may in fact inhibit diabetic retinopathy, and it's probably sensible to measure macular pigment in our patients with diabetes. I think a biological case can be made for that. Okay, so that's supplement number 1, zeaxanthin and lutein. Vitamin D. So We know vitamin D also suppresses a whole bunch of inflammatory cytokines involved in diabetes in a number of animal studies. We also know that people with diabetes, on average, have low serum levels of vitamin D. 25-hydroxyvitamin D is lower in people with diabetes, and it's lower still in people with diabetic retinopathy. And it gets lower the worse the retinopathy is. It's that same kind of inverse relationship. And again, it begs the question, the chicken and the egg argument. Did these happen, kind of simultaneously? Is one causing the other or not? So these are a couple of studies that have been done in human beings with type 1 diabetes in one study, type 2 in the other. One was done in the north, one was done in the south. And again, just showing there's this inverse relationship between the severity of the retinopathy and the levels of serum vitamin D. Vitamin D appears to also block vascular endothelial growth factor and block neovascularization, even independently of VEGF. How about curcumin? What is curcumin? It's not cumin. It's an East Indian spice in turmeric, right? So it's the primary component in curry. It gives it that yellowish color. So it comes from the rhizome, the root basically of the turmeric plant. And in animal models, high doses prevent diabetic retinopathy, but really high doses. The problem with curcumin is that it gets metabolized very rapidly, so it doesn't stay in the body very long. So there's a whole bunch of drug companies working on curcuminoids, these kind of these slow-release curcumin derivatives that will have a longer biological activity in the body. It's interesting, there's more than 50 studies going on now in the US using curcumin, IV curcumin, to treat cancer. And I have a friend who's a Boeing engineer that got diagnosed with stage 4 lung cancer last year. And he got chemotherapy, but he went to a naturopath that the chemotherapist, that the oncologist recommended, and they put him on high-dose IV curcumin, vitamin C, and resveratrol on a weekly basis. And so at his last PET scan, the tumor is undetectable now. So that's interesting. It proves nothing, right? Maybe he just got lucky as hell, or it could be both, right, at the same time. Maybe it's both. It's interesting, and it makes me curious about curcumin and its effects. We know that curcumin lowers nuclear factor kappa beta, which is this master inflammatory switch that turns on all the inflammation that goes on in diabetes and diabetic retinopathy. It also suppresses VEGF. It helps clear out advanced glycation end products. Actually helps the body clear them away. And transforming growth factor beta also has been implicated in diabetic retinopathy. It appears to inhibit that. So here's just a little slide that shows various rates of diabetic retinopathy controlled for A1C and duration of disease. And as it turns out, the lowest rates of diabetic retinopathy in the world are in India and in Pakistan, where rates of curcumin consumption are the highest. But they probably do lots of other things there too, more than we do, right, in the West. And so it doesn't prove that it's the curcumin intake, but I think it's interesting.
Well, they're vegetarians, right?
They're vegetarian, right. So, and we already know that meat consumption increases risk of diabetes, and there's inflammation involved with iron metabolism going on. So my advice to anybody that doesn't really want to get diabetes, in addition to all the stuff I said about breastfeeding and drinking coffee, is avoid sodium nitrite and nitrate preserved meats. Because those compounds are related to streptozotocin, and that's the drug they inject lab rats and mice with to cause diabetes. It kills off the cells that make insulin, and it's very chemically similar to sodium nitrate and sodium nitrite.
It's preserved meats, right?
So it's preserved meats. It's the preserved packaged luncheon meats, right? Am I going too fast, too loud? Slow down, have a sip of water, come around, and
yeah, chill out.
I'm sorry.
Shows true passion.
No, I am passionate. The thing is, I want to get away from myself, and then you can't. Wherever I joke about this whenever I speak. Wherever I go, there I am. Right? I want to get out of my own kind of persona and be somebody else for a while. I don't know how to do that other than consuming drugs. And those days are behind me because it has really negative impacts on my blood glucose levels. Although, just a quick aside, I thought this was really fascinating. My roommate in college, I went to college in Providence, Rhode Island. My roommate in college is the West Coast editor for Associated Press. He lives in Phoenix, Arizona. I hadn't seen him in 10 years. We got to get together because we shared the same birthday. And I hadn't had more than a beer in 15 years. We got hammered. And I took no insulin And we had a huge dinner, and my blood glucose was 85 in the morning when I woke up. I took no insulin that day. In fact, I did not even have my insulin pump hooked up to me. So I found that to be interesting. And that's why I think endocrinologists tell their patients with diabetes don't tie one on, because especially if you're on insulin, it mucks up your liver's ability to produce glucose. Part of the liver's job is to keep your glucose levels elevated if they drop dangerously low. And clearly what I did is I impacted my liver's ability to keep my blood glucose levels elevated. But I digress. Pycnogenol. Has anyone heard of this particular compound? Yeah, it's a patented extract. Yeah, you've heard of it, right, Corey?
I've heard it twice.
Well, you've seen it a few thousand times now. So it's a patented extract of French maritime pine bark. They've done, there's like 30 randomized controlled clinical trials showing that pycnogenol has all sorts of health benefits, that it lowers pain scores in people with systemic lupus, that it reduces tinnitus, ringing in the ears, that it improves painful pregnancy symptoms, that it reduces pain from menstruation, in fact. There's studies showing that it helps with ADHD and with asthma, just a whole bunch of small but randomized controlled clinical trials. Now there's 4 studies that show that it has benefit in diabetes, that it lowers blood pressure, actually fairly substantially. So in one study, patients were able to cut their blood pressure medication levels in half by simply taking pycnogenol. It's an ACE inhibitor. It works just like the prils do, lisinopril and enalapril, those ACE inhibitor drugs. But it also lowers hemoglobin A1C a bit at high dose. About 0.5, about half a point lowering of hemoglobin A1C. In addition, biologically, for my purposes in terms of maybe affecting the eye, it blocks nuclear factor kappa beta like curcumin and vitamin D do, and so does zeaxanthin, by the way. It lowers VEGF, and it inhibits this critical enzyme, matrix metalloproteinase 9. Right there. So MMP9, these matrix metalloproteinases, I'm not a proteomics expert, but these are proteins involved in vascular damage. And MMP9 in particular has been implicated in retinal vascular leakage, like in diabetic macular edema, in central serous retinopathy. And so basically what's thought to happen with pycnogenol is that it seals leaky capillaries. It's almost like spackle patching up the blood vessel from the inside out. And there's a couple of studies showing one was a field study, so it's not a randomized controlled trial, but people on pycnogenol in general had improving retinopathy over time. And there have been a couple of randomized controlled clinical trials as well. One, did I have it up here? I know I moved on to the next one there, but the one trial that was done in human patients in Germany a couple years ago, because that's where this extract was patented, was in Germany. Horpag Pharmaceuticals. It's very expensive. They showed that patients with diabetic macular edema had improved retinal blood flow and reduced retinal thickening using pycnogenol, which is interesting. The problem with the study, it's only got 40 people in it, and they used ultrasound rather than OCT, high-resolution ultrasound, which until I came across that article, I had not seen that being used for purposes of looking at macular thickening, but that's what they did. Benfotiamine. Has anyone heard of this particular compound that hasn't heard me speak before? So what it is, it's a fat-soluble version of vitamin B1, thiamine. And it ramps up an enzyme called transketolase, which basically takes glucose and it diverts all of the harmful glucose metabolites to an alternative glucose pathway. And it lowers these harmful intermediate metabolites. So about 10 years ago, a paper made a big splash published by a diabetes researcher who's up for the Nobel Prize in Medicine now for his work in this area, showing that benfotiamine totally prevented diabetic retinopathy in rats. So most of my patients aren't rats, is always my joke. Some of them are. But it's interesting that it totally prevented it in rats. So it blocks 4 key pathways involved in diabetic retinopathy. And I'm going to go back now to the heart of the diagram I showed you at the beginning, which is this. So hyperglycemia led to all kinds of crappy stuff, right? But in the middle of it all were these 4 pathways. These 4 pathways that lead to oxidative stress, to blood-retinal barrier breakdown, and to neovascularization. So what benfotiamine does is it diverts all of these intermediate pathways using something called transketolase to the pentose phosphate shunt. It's an alternative biochemical pathway to get rid of these 4 pathways. So when benfotiamine is introduced, those pathways essentially are normalized. So the question is, where do all the supplements I just talked about, and maybe some others, fit into this whole network of cross-talking variables that lead to diabetic retinopathy? So I tried to kind of plug them in here. Now, so D stands for vitamin D, P is pycnogenol, B is benfotiamine, C is curcumin, L and Z is lutein, and Z is xanthan. There's one other one I added there. This is from a publication I did for Review of Optometry. I also have lipoic acid in there, which is LA, right there. So lipoic acid also has some beneficial effects, which I'll just tell you briefly about. It's been shown in animal models of diabetes that lipoic acid prevents what's called harmful metabolic memory. Have you heard of this concept of metabolic memory in diabetes? Here's the whole notion. That if your blood glucose levels are really high early on after the diagnosis of diabetes, your cells are damaged and they remember that initial insult. So even if you control your blood sugar terrifically well from that point on, you're way more likely to end up with severe complications than patients who have great control for the first few years and then go down the toilet as years go by. So there's a delayed metabolic memory that actually harms people. There's also a protective metabolic memory that helps people if they get good control early on. Do you need to get by? I'm sorry.
I don't want to interrupt you. Like another one.
So the notion here, there's 2 points from this that are really important, I think. One is that lipoic acid in animals prevented harmful metabolic memory. The other thing is we want to do everything we can to promote favorable metabolic memory. And what that means is right after you're diagnosed, you need to get tight blood sugar control. You can't wait 10 years to get good blood glucose control. Is that the way what most patients do? No. Most patients start off being poorly controlled, and typically it gets better as they learn how to manage their disease as time goes by. That's especially true in people that are on insulin therapy. And that includes people with type 2 diabetes. The majority of people with type 2 diabetes actually, before they pass, end up on insulin therapy. It's a progressive disease. So when people tell me I have the good kind of diabetes, I shake my head. That's not true. There's no good kind of diabetes, first of all, and type 2 is a progressive disease. And actually there's more complications associated with type 2 than with type 1 from a cardiovascular standpoint. So these are some of the other candidates, and in fact everything that's on here was basically thrown into this new test formula that we're testing in the diabetes visual function supplement study. So alpha lipoic acid is at the top of the list because of its effects on metabolic memory. We also have some fish oil in there because that's been shown in animal models to help with retinal ganglion cell apoptosis. We have these other kind of plant-derived extracts like grapeseed extract and resveratrol, which lower reactive oxygen species. In fact, the ARIDS nutrients in and of themselves in a lab model, in an animal model, helped minimize the progression of diabetic retinopathy. CoQ10 is a particularly potent mitochondrial antioxidant. And where these reactive oxygen species are created is by the mitochondria. So anything that can quench those, that can neutralize free radicals generated by mitochondria is a good thing. And that's what CoQ10 is able to do. Alpha lipoic acid also basically goes to the mitochondria. The problem, and the question always is, well, why don't antioxidants prevent disease? If this whole notion of free radicals cause disease, if that's right, why don't antioxidants prevent disease? In large measure, the studies that have looked at antioxidants for many diseases have not been as successful as we would have hoped. So there's a number of reasons for that. One is, they didn't use the right antioxidants or the right dosages, right? Or the right form of antioxidants. Another is these are short-term studies. You need to look at people over a lifetime. You can't just look in 5 years and say, do you do better, do you do worse? It may not be enough time. But the other reason is that free radicals don't get produced once in a while. They're produced constantly. Antioxidants gobble up free radicals on a molecule by molecule basis. So that means you have one reactive oxygen species, and let's say CoQ10 is available. A molecule of CoQ10 gets gobbled up. It basically sacrifices itself to quench that one free radical molecule. So the antioxidants get used up. So what you want, and what there's a lot of work on, is what are called catalytic antioxidants, that they gobble up the reactive oxygen species, but then they regenerate themselves to quench more free radicals.
Before you go on the previous slide,
yes, sir.
You had LA.
I'll go, yeah, for lipoic acid.
Is that alpha lipoic acid?
It's alpha lipoic acid, right? Yeah. Yeah, sorry. I tried to squeeze everything on, so I abbreviated it. It's alpha lipoic acid. And as it turns out, I've written a couple of pieces about lipoic acid now. What's sold at most super supplement stores is a racemic mixture of R and S isoforms of alpha lipoic acid. And the studies seem to show that it's the R form which is more bioactive, more bioavailable. The S form doesn't have as much biological activity. So did I go through all the candidates? I did. Green tea, so green tea blocks epigallocatechin, which is plays a role in VEGF production. So green tea seems to. Stuart Richer sent me a really interesting paper. It was from China, but I think really interesting, that looked at rates of lung cancer diagnosis in China based on green tea consumption. So I tell my patients who smoke this all the time. They showed that if you drank 2 cups of green tea a day, and in the general population, 80% risk reduction in being diagnosed with lung cancer. And if you're a smoker, 95% risk reduction in diagnosis of lung cancer in a dramatically, like millions of people, cohort that was retrospectively analyzed. Again, it may be people that green tea do other healthy things. It doesn't prove the point, but I think that's interesting. Green tea is active against VEGF. And so for my purposes, it may have a role in diabetic retinopathy. There's a number of retinal kind of biologists that have used it in various AMD supplements for potentially beneficial effects. So if you want to learn more about this stuff, this is the article I worked my tush off on for Review of Optometry that got published in December. So I wasn't happy with the cover because it didn't really sell people on the whole idea of what the article was about, which was micronutrient intervention. They asked the rhetorical question, can we move the needle in diabetes? But the question was, can we use micronutrients to have an effect on diabetic retinopathy? So if you get to the article, it was supposed to be the featured article. You can read more. You can look at all the references that talk about the stuff that I've kind of quickly gone over in the last 20, 30 minutes. We're actually going to talk about the study here. So here's the test formula. Should I stop for a moment and entertain questions? Anything that makes zero sense?
Sir Richard talks a little bit about Longevinex. What's your thoughts on that? Because, Bill Sardi will say, well, it's not just resveratrol, it's
right.
The right amount. Because if you get too much, it's a problem. If you don't have enough, it's a problem.
Right.
And so, what's your thoughts on Longevinex?
So I'm not an expert in resveratrol biology, and so Stuart's a friend of mine. I think he's really smart. I'm persuaded by him. I've looked at the papers. The papers suggest that resveratrol, any form of resveratrol, actually improves insulin sensitivity. And there is one animal study that suggested it retarded diabetic retinopathy. So Longevinex is a product, it's a patented micronized version of resveratrol essentially, where they've added in a bunch of microRNA molecules that somehow is supposed to make the product, to make the resveratrol more bioavailable. And Stuart shows some pretty compelling photographs that I've seen of people with really bad end-stage AMD, where they've lost vision, their count fingers vision, and in a matter of a few weeks, by OCT, you can see retinal pigment epithelial cells regenerating, and people's visual acuity improving, 7, 8, 10 lines on the eye chart. I mean, you look at it and you go, that's got to be made up. That can't be real. He's somebody that I trust, and so I take him at his word when he says it's real. Is that the optimal form of resveratrol? My opinion is biased by the fact that I've been taking the product for the last 5 years. And I feel pretty well. But that proves nothing. So I believe in it. Yeah. I believe in it, but that doesn't prove anything. So what you need is a head-to-head of that particular form of resveratrol.
Well, he recommended the level for this formula, too.
He recommended...
We took his
the level. So the level of resveratrol we used in this formula was recommended by Stuart Richer. That is correct. No, it's not the micronized form, though, to my knowledge, right? It's not the micronized form. But Stuart made the recommendation for the amount that we put in. So what's in the formula is lutein, zeaxanthin, benfotiamine, lipoic acid, alpha lipoic acid, vitamin D. We threw in vitamin C and E that work better together than either one alone, mixed tocopherols and tocotrienols. So we have all the different moieties of vitamin E involved, not just D-alpha tocopherol, which is what's always studied. Resveratrol's in there, green tea extract, curcuminoids, highly bioavailable curcumin, N-acetylcysteine, which I didn't go into that, but there's some evidence that that may actually retard capillary leakage, grapeseed extract, CoQ10, there's some zinc in it because people with diabetes tend to be deficient in both zinc and magnesium. There's some fish oil in it, and there's pycnogenol. So basically, whatever we could think of and throw into 2 capsules. So when I first brought this to Dennis, we were brainstorming about what should we put in the formula and how much. And when we sat down at the table together, we realized, you're going to have to drink a gallon of liquid every day to get all of these things we wanted. So we had to make some strategic decisions about how much can people afford? How much could we afford, first of all, to put in it? How much are patients willing to spend, and how many capsules a day? Right? It's the same issue that faces any kind of supplementation, is what can you cram into 2 pills? And I think we struck a good balance, and we'll see if the data bears that out. So I'll show you some of that in a moment. So the test formula was given to rats in their rat chow by Dr. Colleroux, who's the one that posed that provocative question about, will an ARIDS type formula work for diabetic retinopathy? And so in a rat model of diabetes, the test formula blocked mitochondrial damage in the rats. It blocked retinal capillary apoptosis, which is thought to be kind of one of the underpinnings of diabetic retinopathy. And it also improved the electroretinogram. So it improved all 3 things: structure, function, and retinal metabolism. So it's really the first time in an animal model that all 3 things, structure, function, and metabolic parameters, have been shown to be improved by some sort of supplementation. This was presented at ARVO this last year, and now it's recently published in Nutritional Metabolism. So the paper just was published. So these are some of the figures from the publication looking at what happened to these various blood markers. So on the far left are the normal rats, in the middle are the diabetic rats, and then you have she labeled it carotenoids with antioxidants. That's the test formula. And so VEGF levels were essentially normalized in animals with diabetes compared to animals who were not so supplemented. Nuclear factor kappa beta, this master inflammatory switch, was also normalized. In fact, in the supplemented animals, it was better than in the normal animals without diabetes, better than in the control animals. In terms of retinal dysfunction, that's the electroretinogram. Animals did about as well on supplement as the normals did, so they improved on their retinal dysfunction. Capillary cell apoptosis, this is normal, diabetic rat, so it didn't reduce to the normal level, but a dramatic, statistically significant reduction in apoptosis of retinal capillaries. Oxidative stress went way down, mitochondrial damage went way down, the number of functioning mitochondria. So it begs the question, will this work in humans, right? That's ultimately what matters. So this is the study I'm doing, we call it DIVFUS, Diabetes Function Visual Function Supplement Study. So it's a 6-month study, randomized, placebo-controlled, of people with both type 1 and type 2 diabetes. They have to have had diabetes at least 5 years. They can have retinopathy, but it can't require treatment. So it has to be mild to moderate non-proliferative retinopathy, or macular edema that does not qualify as clinically significant macular edema requiring treatment. We also have a number of patients that have no retinopathy in the study. We want to see if there's a difference between the groups. And so they use this multi-component supplement that has all the components I just showed you. And what we're looking at is their contrast sensitivity, their macular pigment optical density, their color vision, using a desaturated Lianthony color vision test, which there's some studies say that it's useful in diabetes, but my experience has been that people with diabetes longstanding have a lot of blue-yellow color vision defects. And so we wanted to see, would this improve their dyschromatopsia, their blue-yellow defects. We did macular perimetry, so we did a 5-2 threshold visual field. OCT, we measured their A1C, their lipids, their vitamin D in the blood, tumor necrosis factor alpha, and their high-sensitivity C-reactive protein. The final thing we threw in was a diabetic neuropathy symptom score. It's a validated 4-question simple quiz that you can give your patients to find out what level of diabetic sensory neuropathy they have. And this is clinicaltrials.gov identifiers there, and CA Vision is funding this whole study. So far, we have 62 people enrolled. Right now, 34 have completed the trial. Actually, I think I have like 45 or something that have completed it. But for the Academy of Optometry this year, I was asked to give a presentation. So we've unmasked the first 34 to complete it, and we analyzed the data. So of the 62 subjects, these are kind of some of their data, and the bottom line here is that people that had diabetes longer had more retinopathy. No surprise, right? People with type 1 diabetes had more retinopathy. No surprise. People with poor A1C had more retinopathy. Again, no surprise. And there were about equal numbers in both the supplemented and the placebo groups. And this is the key thing really there at the bottom, is that when the biostatistician looked at all of this, she found no statistically significant difference between the placebo and the supplemented groups at baseline. So we're comparing apples to apples. It's not a lot of patients, though, yet. Now, as I said, we're above 60. We're trying to get 75. But we have 34 analyzed, which is what I'm going to talk about now.
Are these all within your practice?
These are all in my practice, and they're all either my patients or patients that were referred to me by a local retinal specialist who's doing kind of a retinal examination, and he's independently doing OCT analysis on these patients. And that's a problem with any study. You have one investigator, one site, right? It looks, so I feel the same. So we had so much trouble trying to get IRB approval. And all of the docs affiliated with academic settings, said that our IRB will not approve a multi-component supplement. It has to be one ingredient so that if something goes south, we know what to discontinue. And if your patients are harmed in some way, we won't know what the problem is. And I understand philosophically the argument. But I wasn't able to get other sites enrolled to start enrolling patients. So it's a single center trial, and that's its weakness. Here's the first subject to complete it, and I know now, I didn't at the time, that she was on supplement. So she's had type 1 diabetes, 36 years, had mild non-proliferative diabetic retinopathy. Her MPOD after supplementation went up dramatically from 0.18 to 0.48. Her HDL increased about 20%. Her A1C, her LDL, her triglycerides, and her tumor necrosis factor alpha, they all got worse. Some of her blood markers got worse. So is that due to the supplement? Potentially. Her A1C went up, and I'll tell you this, it's anecdotal, but as someone with type 1 diabetes, your A1C is variable. It goes up and down all the time in response to a whole bunch of factors. You eat too much bread a few nights. You get sick. You have more stress in your life. So it may or may not have anything to do with the supplement. But what I'm going to show you is that her visual function improved, and so did her retina, even though some of these markers got worse. So her contrast sensitivity got better. Her color vision dramatically improved, and her visual fields improved. She had a long-standing, I'd followed her for 8 years, a long-standing large retinal microaneurysm that went away at the end of the trial, which proves nothing. But she also said, I'm seeing better. I just feel like I see a whole lot better. And one of the reasons maybe her MPOD went up so much. So here's her contrast sensitivity. So it's right eye, left eye. So the solid lines are the pre-supplement, the dashed lines are post-supplement, and that's a contrast sensitivity function. And you can see her contrast got dramatically better. Here's her color vision test, and this is a desaturated D15 essentially. She had what's called a tetartan defect, which I don't think I learned about in optometry school. It's kind of related to a blue-yellow tritan defect, but her tetartan defect went away on follow-up. And what we're doing, just so you know, is we're doing it 3 times, and we take the best of the 3. And that's at baseline. On the follow-up, we did it 1 time. So we were trying to kind of average out the beginning to make sure people understood the test, had the best possible chance. And the best she did is she had this clear crossing defect on this desaturated D15 test that essentially went away 6 months after being supplemented. So here's the microaneurysm right there. It's a pretty big microaneurysm, and it had been there for almost a decade. I have serial photographs showing that, and at the end of the study, it's gone. So that's cool. I mean, but that proves nothing, right? It went away. It's really interesting. I was excited about it. She was excited about it and said, give me more of that supplement, right? I want more. And I said, well, I don't know if you were on the supplement, so we got to wait and see. Her macular perimetry improved. So she had a lot of her visual field points got better. So far more got better than got worse. And her mean deviation improved. She had a negative 1.43 mean deviation, and actually it went to the positive direction. So she didn't have a statistically significant abnormal mean deviation on her 5-2 visual field. So this is all the data for the first 34 patients we've looked at, looking at these parameters. So for contrast sensitivity, averaging it across the contrast sensitivity function, the supplemented subjects did about 30% better. The people on placebo were about 20% worse at the end of 6 months. The color error score, so the higher the score, the worse your color vision. So the color error score went down. It was cut in half in people on the supplement, and it got a little bit better, 2% better in people on the placebo. The 5-2, just looking at the mean deviation, it improved about a point on supplemented people. It improved a fraction of that in the placebo group. The one that got me the most excited was the next one, high sensitivity C-reactive protein. It dropped by more than 70% in the people supplemented. So what I'm anxious to see is in the rest of the study cohort, does this hold true? The people in the placebo group, their CRP actually got worse. And I'll show you. So CRP is a risk factor for cardiac death. That's been well established. A1C went down a little bit in the supplemented group, got a fraction worse in the placebo group. OCT did not change, which is really not surprising. It's only a 6-month study. None of these people had clinically significant macular edema, so that didn't surprise me. For contrast, color, visual field, and high sensitivity C-reactive protein, the p-value was less than 0.04, so statistical significance in a small number of patients. So this is the overall contrast sensitivity function for the whole group. So here it's not right and left eye, it's placebo and supplemented group. So the supplemented group is in black. So pre-test is solid, post-supplement is dashed. So you can see the black line gets better. Their contrast improved. And in the group on the placebo, their contrast actually got a little bit worse, especially at 6 cycles per degree on the contrast sensitivity function. So you don't know what you're going to find. You're recording all the data, and you go down and you plot it out, and you start to see these patterns emerging, which are interesting. This also surprised me, this diabetic peripheral neuropathy symptom score. So basically you ask 4 questions. Do you have problems with balance when you walk? And patients say yes or no. If they say yes, they get a point. Do you have numbness or pain or aching, burning in your feet or legs? You get a point for that. Do you have prickling or a pins and needles sensation in your feet or legs? And finally, do you have any numbness in your feet or legs? So you add up, it's just, it's simple addition. You add them up and you see what their pain scores are. So pre-trial, the people in the supplemented group had an average score of 2.6. After the trial, it was 1.6. So their peripheral neuropathy symptom score went down a point, which is interesting. The supplemented group, it started at 2.5 and it ended at 2.5, so no change. Interesting. It was statistically significant. So the summary of the early findings is that this formula that we're calling the DIV-FUS formula significantly improved visual function, including contrast sensitivity across the whole spectrum of spatial frequencies. It improved visual field sensitivity and color perception. Remember, the color score was improved by about 50%. And it significantly reduced high sensitivity C-reactive protein and diabetic peripheral neuropathy symptom scores. So why is CRP a big deal in terms of diabetic retinopathy? Here's one recent paper that maybe points to that. So the Diabetes Control and Complication Trial, we've all heard of that? All type 1 patients, done in the 1980s. One of the cool things they did is they took blood samples and they froze them. So now they're going back 30 years later, and they're looking at the blood, and they're saying, the people who ended up with severe vision loss, is there anything remarkable about their serum samples? And what they showed was that if you had high levels of C-reactive protein, you were significantly more likely, 80% more likely, to be diagnosed with clinically significant macular edema in the intervening years. So anything that lowers C-reactive protein, at least in type 1 patients, the argument might go, would lower the odds of developing clinically significant macular edema. Of course, it doesn't prove the point. You can only do that by supplementing and following people for a long time, right? So it's a surrogate. But it's an interesting surrogate. I threw this in mostly for dentists because I wanted to show them. This is patient number 38. So I analyzed through number 34. This patient came in. This is her left eye pre-treatment, pre-supplement. And I didn't know if she was on placebo or not. And this is 6 months later. You can see a pretty dramatic improvement in the diabetic retinopathy status there. So I asked my office manager to do one thing, because she's the one who's privy to who's on placebo, who's on supplement. I don't know who's on what. And she went and looked it up, and I said, I want to know one thing. I didn't want to know, I don't even know which patient it is. I wanted to know the gender. I wanted to know if it was type 1 or type 2, and was this patient on supplement or placebo. So this is a patient with type 2 diabetes, female, and the patient was on the supplement. Interesting, not conclusive. So the DivFus formula, I'm not using it in my practice yet because I'm the trial investigator and I think there's an ethical conflict there. I want to use it and recommend it to my patients, but I have to wait. I'm morally obligated, in my view, to wait till the end of the study to start recommending it to people. But the formula is now available through ZeaVision as I Promise DVS, which I believe the acronym is supposed to stand for Diabetes Vision Supplement. Or support, forgive me, support. Diabetes Vision Support. So the issue is with the FDA, they're really being very punitive and careful about claims made by new supplements that come to the market. So there's lots of old supplements that say they improve diabetes, and even though they have really no data to show that. And the FDA is leaving those companies alone. It's the new companies that make new claims that they're really scrutinizing. So we kind of got cold feet about what we wanted to call the product. So unfortunately, it doesn't have diabetes anywhere on the label. But as a healthcare provider, and as healthcare providers, we can talk about it, and I can tell you that's what its intention was to improve blood vessel health, specifically in people with glucose dysmetabolism, right? People with diabetes or glucose anomalies. So this is just the label on the vial showing the various ingredients. Now, we have a proprietary blend of some of the stuff that's in there, and if you want to know the amounts of each, we can provide that. I don't have it handy here at least, but I know the various amounts that are in there.
We have sheets over here, Paul.
We have sheets that detail the amount, how much of this proprietary blends, I don't really know, why did we use a proprietary blend? Just, is it to protect intellectual property? Is that the idea?
Well, just make it a little proprietary.
Right.
But it just can complicate the manufacturing process, because some of these things are impossible to analyze.
Some of the things can't, some of the constituents you couldn't analyze.
Really hard to analyze.
Okay. So you know you have a set amount, but it's hard to know what percentage of each amount is in there. Okay.
So you have about half the amount of zeaxanthin and lutein in these versus I Promise.
That's correct, right? Yeah, it's 8 and 4. 8 zeaxanthin, 4 lutein. How much we could fit in a capsule? The capsules are fairly large, and the cost. So what is the cost of this? Is it $39, something like that, a bottle?
Yeah,
It's kind of
it is a little bit more expensive than I Promise Restore because of the extra ingredients and nutrients
Right.
in it. Yeah, so it's about $4 a bottle.
So pycnogenol, just to give you some sense of it, Dennis brought this to my attention. Pycnogenol is $10,000 per kilogram. Things like zeaxanthin is what?
5 to 10,000.
5 to 10,000 a kilogram. But most of the things were, fish oil, EPA is like $300-400 per kilogram. So it's
Dr. Brill, it has the same amount of zeaxanthin and lutein and the same ratio as one I Promise Restore soft gel.
Right. So if we have somebody on EPR, what do we tell them?
So you're probably, if they have diabetes, that would be the time to introduce them to this supplement, and they're still going, as you saw in Paul's slides, they're still going to have an MPOD increase. So you're addressing that component.
But maybe not, if they've got AMD, not as. I mean, it's a great question. So I'll tell you what I'm doing. I don't have any. All I can say is this is what I've been recommending to my patients. If patients have more than mild non-proliferative retinopathy, I've been telling people to take not 2 a day, but 4 a day. I'm doubling the dosage.
Or
4 of this a day.
I thought you said you weren't doing that. I'm sorry.
So that
For the study.
so I have a couple of patients that I'm not selling them product. I have bottles and bottles and bottles of this sitting in my office, and so I'm trying in a few select patients who did not require treatment double the dosage to see if it will have any effect. I have a couple of patients that have gotten multiple Avastin injections and are getting worse and worse and worse and worse. And I wanted to see would it have any effect on that. So we're talking now, ZeaVision is, somebody that contacted me out of the blue is a retina specialist in Gainesville, Florida. And he wants to do a study seeing in patients with clinically significant macular edema, half the group would get injections, anti-VEGF drug, the other half would get the same treatment plus the DVS formula. And what you're looking for, of course, is improved outcomes, reduced injections. Will that happen or not? So I promised DVS basically, it's nutritional support for retinal health is kind of the moniker on this. And if you want to get this booklet, we have them here tonight because we're not COPE approved, but I give you a link, a way you could get it. I'm a little frustrated so far with the launch of the product, and I've already told the folks at ZeaVision this, because I can't, if I go to the Zia website, I can't find the DVS product anywhere. It's hard to find it. I have to Google it, and then it'll bring me to a page where it's available. So we just haven't really ramped up promoting it. And whether or not we, I guess I'm frustrated because I want to have an impact, but I really shouldn't say that until the study is completed. I'm convinced at this point it improves visual function, and in rats at least it had a showed a tremendous improvement in a whole bunch of biological markers. And so will that spill over into human beings? With the C-reactive protein data, I think that it's something that's worth entertaining. So the final thoughts: diabetes and retinopathy rates are growing at alarming rates. It's a pandemic, really, worldwide. The highest rate of diabetes growth is actually in sub-Saharan Africa, in terms of percentages. Preventing diabetes and retinopathy will save lives, vision, and a lot of money. Last year, the U.S. spent $245 billion just on diabetes care. So that's a Hurricane Katrina and a half every year spent on treating complications of diabetes, most of them cardiovascular, right? Because that's what costs all the money, is doing coronary artery bypass grafts. So the other concluding remark is, we know improved metabolic control has a major impact on getting diabetic retinopathy, but many people don't achieve those ends. And even those that do, some of them end up losing their vision. It makes biologic sense, at least, to try to target these individual pathways on that diagram I kind of sort of described to you. If we can intervene without necessarily lowering blood sugar or blood pressure, but to actually block the chemical mediators of diabetic retinopathy, somehow that just makes sense to me from a biological standpoint. So my challenge to you is don't just tell patients that they need good control. Think about diversifying your portfolio. Think about recommending maybe some of these scientifically based micronutrients for preventing diabetic retinopathy. Treat your patients the way that you would want to be treated as a patient yourself. Diversify your portfolio. So I want to thank you for tolerating me for so long. I'm happy to keep talking and answer any questions that I'm able to answer. Thanks, everybody.